So it's nice to see you again here at the CRISP TV conference in Mumbai 2024. My name is Dr. Abad Khan. I am an interventional cardiologist practicing at St. Joseph Hospital, Ghaziabad. And with me today, we have Dr. Ajit Menon, sir. He is a very important guest and also no new name for the interventional cardiology community, and has been a clinical and interventional cardiologist for many, many years, dedicating his life and expertise on imaging, and recently on the drug-eluting balloons also. Welcome to the CRISP TV. I have a question for you, sir. What do you feel that the current knowledge gaps are there in clinical usage of imaging? Even after the landmark trials of IVUS and OCT published, are there still the knowledge gaps which remains?
Yeah, you're absolutely right in this question. Are there knowledge gaps? Absolutely, there are knowledge gaps. We need to go into the reason why these knowledge gaps happen, because all of us, when we undergo training in cardiology, we have training on angiographies, on angioplasties, on procedures, but training on intravascular ultrasound or OCTs is there, but it is not a separate field. It's an integral part of the procedure. So whether you learn or not depends upon what is your level of acuity, what is your level of involvement in the procedure, and how much do you want to learn out of the procedure. If you see abroad anywhere, most of the centers, either in Europe or in the US, have dedicated people who are trained in OCT and intravascular ultrasound to guide the interventional cardiologist. There are certain other reasons for it. One is that we have that much limited time in doing a procedure. We don't have a lot of time on our hands to do a procedure because cath labs are full up back to back. There are people waiting to do procedures. You can't delay the lab too much. Doing an IVUS or an OCT does take time. If you need to do a proper interpretation, if you have to do the procedure yourself, interpret the images yourself, and come to decisions yourself, you're going to take a lot of time in doing these procedures. That's where there's a little hesitation in doing an intravascular imaging in procedures with complex interventions. Second, doing a procedure is very simple. Interpreting it is difficult. And automatically, when you have a difficulty in interpreting an image or interpreting a procedure, you're going to back out of it. You're going to feel that I don't need it. I can do the angiography. I can see the vessel. I can do the procedure. One of the reasons is that you don't know, or you're a little hesitant in proper interpretation of an IVUS or an OCT. So once a person gets trained on the IVUS or the OCT, automatically, I can tell you with my own experience that your need or your usage of intravascular imaging will automatically go up because of the amount of information it gives us. And not only that, the amount of safety and satisfaction that it gives us to end a procedure and be sure that this is the best I can do. This is a result which is absolutely optimal, and I'm sure nothing can go wrong in these patients, at least in the acute phase. That's something which no other modality of investigation will tell you. There are gaps basically in training, and those gaps in training are leading to gaps in the usage of the technology. Not only that, cost is another hindrance in using it because it pushes up the cost of the procedure by a fair amount of money. And most of our patients, though they are insured, the insurance limits are small, and in some instances I have seen that insurance companies also do not pay for these procedures. I think that's also a lack of understanding for the insurance companies also. They ask us questions as to why was this used. Now, we know that intravascular imaging and OCT has a class 1 indication today, which means that you are absolutely right in using this in the interest of the patient's procedure, in the interest of patient safety. So I think once these are all bridged up, and the learning of OCT becomes, or OCT or IVUS for that matter, becomes a bit more aggressive, and people start getting trained in the procedure and the interpretation, not in the procedure, in the interpretation of the procedure, I think the usage will definitely be a sea change in the usage.
So great. As I said, that you need to have a dedicated teaching program right from the basic when you start your program, from the teaching program, from the learning days. The interpretation for it, the time management you need to learn to perform these procedures, and obviously at the end of the day for the clinical usage, cost also plays a part. So yes, sir, I agree to that and to almost all the answers you gave. And do you believe, sir, that the class 1 indication which has been recently published in the ESC 2024 guidelines, will that bring about a paradigm shift in the usage of the intracoronary imaging in India, sir?
Whether class 1 indication of the European Society guidelines will change and bring about a paradigm shift, I am not sure. Honestly, not because of anything else. Getting a class 1 indication just means that it's a good indication to use it in any procedure. It's a guideline. It's not a diktat. And because it make you much more comfortable in using it, number one. Number 2, it will justify the use of a device in complex interventions. Number 3, you can always justify to the insurance companies your usage of a device when you're looking at such a high cost, and insurance obviously is not ready to pay those costs. But again, you need to realize that though insurance is there, it's still limited, not only in numbers, but also in the amount of insurance. So unless all those barriers are crossed and it becomes easily affordable for everyone, I think we're still going to have a little bit of hesitation in using these imaging devices. Second, like I said, the day we have a dedicated training program for intravascular ultrasound and for optical coherence tomography, and there are people who are trained in these procedures, like you have ultrasound specialists in radiology, you have intravascular imaging specialists in cardiology. That's what's going to make a sea change in the usage of the device, because the interventional cardiologist then will want to use it in each and every procedure, because he has a person who's going to interpret it. The time taken for the procedure is reduced because everything is kept ready and you just have to do the procedure. Someone does interpretation for you, you continue your procedure. You half the time that you take now for doing these procedures. When all these things come in, definitely make a lot of difference.
So as sir rightly pointed out, that to bring about the paradigm shift, it's not only a class 1 indication, it's the affordability that remains a bridge here, and the expert training at hands. If you have an expert trainer who has been trained immensely in intracoronary imaging and he is available at inside the cath lab, inside the procedure time, then definitely that should bring about a paradigm shift. And so lastly, sir, continuing on this topic of intracoronary imaging, so after the latest more controversial PREVENT trial, which was published recently in 2024, ESC EuroPCR, do you see any other imaging modality also coming up apart from IVUS and OCT, like IVUS NIRS or IVUS and OCT combined catheters that are going to come despite the limitations of cost we see?
I think the PREVENT trials showed that when you have a high lipid plaque burden, your chances of future events are higher, and that's the concept of the vulnerable plaque.
Yes.
I think when you use the IVUS NIRS system, the advantages to me is that you can quantify the plaque, whether it's a lipid-rich plaque, and a large lipid burden will make you a little aware that these are areas where you don't go very high on your balloon pressures, or you don't use certain devices when doing an angioplasty, because the risk of embolization, the risk of slow flow, etc. is extremely high. So does it help in those situations? Absolutely. We have used it and we have found the difference when we find such high lipid-rich plaques. And we have seen the disasters that happen when we have used high pressures and you have massive embolizations distally. So I think there definitely there's a role for the NIRS IVUS. Does it mean that I'm going to treat vulnerable plaques which are 50%, 60% area narrowings in these lesions? I still don't believe that I would do it. I would still feel I would leave these medications on medical management, keep a regular follow-up. Is it worth the cost-benefit ratio to do an intravascular ultrasound in an otherwise asymptomatic patient with a non-critical blockage and detect that there is a plaque burden, lipid-rich plaque? I'm not sure about that, honestly. But yes, it has its own utility. It is definitely used in detecting lipid-rich plaques, which is a harbinger of future events or complications during the procedure. So there is a role of it. The same technology has been extended to a single catheter where they use intravascular ultrasound and OCT in the same catheter. Definitely, you can, because there are certain situations where an IVUS is helpful. There are certain situations where an IVUS is not as helpful, and OCT definitely has some advantages. So in those situations, if you have a combined catheter which will image both an IVUS intravascular ultrasound and an OCT in the same catheter, why not? You can enter the procedure with, even if you have a suspicion of a medial dissection, or if you have a suspicion of a thrombus, or you have a suspicion of a malposition of the stent, definitely, and OCT has a distinct advantage over an intravascular ultrasound. No questions about it. Getting good landing zones, OCT definitely has an advantage in diffuse diseased arteries. And IVUS may not pick up those areas as well as with the new OCT. The thing you can see if you can gauge your external elastic lamina very well, you know that you are in a safe landing zone. So I think there are distinct advantages of the OCT. There are some advantages of the IVUS, and you have a combined catheter which gives you both. It's definitely a good resourceful tool. yes, the cost is something which they have to definitely work on and see that it is affordable to the Indian population.
Thank you for this talk, sir. And we hope to see you, to all of you, for such wonderful tips and tricks from Dr. Ajit Menon, sir, and other cardiologists also. Please come, do join us on October 18th to 20th in Mumbai. Thank you.
Thank you so much, and I'm looking forward to seeing everyone at the CRISP meeting. I'm sure it'll be a meeting with a difference, and I'm sure we will have a lot of educational points that people can take home from this. We ourselves are really looking forward to this meeting. Thank you so much.
Thank you. Thank you so much.